Okay, why is this relic, the precordial stethoscope, important to me, the modern day anesthesia provider? Nothing can be more restrictive than a continuous monitoring of breath sounds through an earpiece. Nevertheless, every anesthesia practitioner is aware of those critical moments of airway uncertainty at the beginning of the case or at the end of every general anesthetic. Continuous monitoring of upper airway sounds during those times can either be very reassuring or they can trigger a more appropriate and timely intervention. Now what we're going to do is we're going to look at the actual endotracheal tube as it applies to a pediatric patient. And what about this endotracheal tube when it applies to our pediatric patient that makes my precordial stethoscope a very important monitoring device? And we'll look at that in the next several slides. Alright, on this slide, what you're looking at is a standard 3.0 cuffed pediatric endotracheal tube. It shows two views, the anterior view and the posterior view. The anterior view, it shows that the endotracheal tube tip is tapered and also that the Murphy's eye is located on the right side. So therefore, the tapering is pointing towards the left lung and the Murphy's eye is on the right lung side. You can know by looking at the endotracheal tube if you're looking down on your patient. So just picture yourself, you're at the head of the bed, you're looking down on your patient, and as you're looking at the anterior view, you should see black hash marks. That tells you exactly the depth of the endotracheal tube, and that is found on the anterior side. Compared to the other photo, which is the posterior view, and there you're going to find there's a blue line. And if you see the blue line, then that means that endotracheal tube has turned upside down. Why this is important is because, as you can tell on the posterior view, when the endotracheal tube is turned upside down, the Murphy's eye is now pointing to the left lung, not the right. Okay, this slide shows an example of the positioning of the endotracheal tube in your patient. So you're at the head of the bed, you're looking down, and you see, as in the picture on the left, I see black hash mark. So I know, okay, the endotracheal tube is correct. That's my anterior positioning. I look underneath the endotracheal tube and I see a blue line. Therefore, I know that's the back of the endotracheal tube. And looking down on this patient, I can say, yep, the endotracheal tube is sitting in that airway in the correct positioning. So now, why is this important? Well, it's important because if it's down this way, then you know that the Murphy's eye is pointing to the right lung. The tapered position of the endotracheal tube is also positioning towards and throwing towards the left lung. Now this sounds very easy to diagnose. I look down on my patient, I easily see black hash marks, I easily see a blue line underneath the endotracheal tube. So why is this important to me? Well, the next slide is going to show you in a pediatric population, we kind of share the airway with the surgeon. The surgeon, the drape's on top of it. We're talking a small baby. The arms are maybe on top of our endotracheal tube. We got everything in our way. So the next picture is going to show you why this is important and how my precordial stethoscope, we discuss shortly, of how my precordial stethoscope can help me figure out which direction my endotracheal tube may be. Okay, here's a picture of why it's so important. This picture represents an infant baby. Now, can you tell which direction the endotracheal tube is positioned? I know I can't. Now, mind you, if you do preemies or micropreemies, you won't even see this much of the head because that drape is going to even be more so on it because the body is so small that it all becomes part of the surgical site. Now, when you're dealing with these small pediatric population, they're lying on top of a bear hugger, which is blowing warm air up at them to the posterior side. You've got big halogen lights that's having heat coming from the anterior side. all this heat, which is great to keep them warm because our pediatric population we want to keep warm, but what does it do to that endotracheal tube? It makes that endotracheal tube very soft and pliable. You have a soft, pliable endotracheal tube connected to a heavy circuit. Also, at the same time, you've got heavy drapes, which is pushing down on that endotracheal tube. You may have a surgeon's arm that's pushing onto your airway also, or they may throw suction tubing or any kind of instruments up there, which is going to weigh that drape down and also affect that endotracheal tube. What can happen with these soft, pliable endotracheal tubes in these small pediatric populations is they can flip around and turn. And what that means is if it turns, that means the Murphy's eye is no longer where it's supposed to be, and now it's facing the left side. So now you've got the Murphy's eye going to the left side. And why this is important is we're going to show you in a few slides why this is so important, because any little millimeter of movement, that endotracheal tube in these small pediatric populations can make that endotracheal tube become endobronchial, or it can make it actually extubate your patient. Okay, this slide, I admit, is a little busy, but it's very important to have them side by side there to explain what's going on. So what you'll see is on the picture on the left, it shows the endotracheal tube in the most proximal position and still be able to ventilate both lungs. The photo on the right shows the endotracheal tube in the most distal position and still being able to ventilate both lungs. Now, when you see the T, what the T is the distance from the glottis to the carina. The L represents the distance from the proximal edge of the cuff to the tip of the endotracheal tube. And if you take the T minus L, that exact measurement is your margin of safety, whereas how much room do you have that your endotracheal tube will not become extubated or will not become endobronchial, as we'll see in the next slide. Now this slide shows your margin of safety, your T minus your L. Basically, what is my safety? How many millimeters can my endotracheal move safely without extubating my patient or without endobronchialing my patient? The photo on the right side is actually the millimeters for the different age groups, from 0 to age 5. Basically 17 millimeters up to 28 millimeters. Now that probably doesn't mean much to you. The next slide is going to show it actually and what that means when you look at an endotracheal tube in the pediatric person. And there it is, 17 millimeters to 28 millimeters. As you can tell, in the pediatric patient, because their airway is so small, it's not much of a distance. So one little heavy drape or one little arm pushing on that endotracheal tube from above can actually push the endotracheal tube down and become endobronchial. Same distance or same thought is if you extend the head. As you know, the tube follows the nose. So if you extend the baby's head or the child's head, the tube can move at any little distance like that, can also cause the endotracheal tube become extubated. As I mentioned previously, the endotracheal tube follows the nose. So if you flex your patient's neck, the nose is going to go towards their chest, and therefore the endotracheal tube is going to go towards their carina, at which time you could end up getting an endobronchial intubation. If you extend the baby's neck or the child's neck, the endotracheal tube is going to pull out, and therefore you could extubate the child. And as you saw on the previous slide, we're talking a small amount with the margin of safety for the endotracheal tube to go, that it's not extubated or endobronchial intubation. Now, all the information I gave before in the previous slide about the Murphy's eye, why was that important, especially in the pediatric endotracheal tube? Well, as you can see on this slide, here the endotracheal tube is in the perfect position. The tip is tapered, so you have airflow going to the left lung as well as the right lung. The Murphy's eye is there, and it's also showing having airflow to the right lung. And as you know, the Murphy's eye is there in case the tip becomes occluded. If the tip becomes occluded, then there will be still airflow going to your patient. So that's a safety measure. And in this case, the Murphy's eye is your friend. Shortly, we're going to see how could your Murphy's eye become your foe? And this slide shows how the Murphy's eye can be your foe. As you can tell on the slide, the endotracheal tube is posterior. The reason you know that is because you see the blue line, which means the blue line is facing you, and therefore you're looking at the posterior portion of the endotracheal tube. If you're looking at the posterior portion of the endotracheal tube, that means your Murphy's eye is now on the left side, and as in this picture, you are endobronchial intubated, but because of the positioning of the Murphy's eye, there will be some airflow going to your left lung. If you were to be listening with your regular stethoscope periodically, you're going to hear the chest and you're going to hear breath sounds on that left side. But what you're not going to realize is that you're actually hypoventilating that left lung. Now, had there been a precordial stethoscope there the whole time, as you're ventilating your patient, you may all of a sudden, as you're ventilating and you're constantly listening to that left side, you may all of a sudden hear decreased breath sounds, and that can give you a pre-warning that your endotracheal tube may have become endobronchially intubated before your monitors or your advanced technology starts to show where your pulse oximeter starts to go down.